Good morning, everyone. My name is Jeroen Schouten, and I'm speaking to you from Nijmegen in the Netherlands. I will now try to share my screen. So today we're talking about the future of antimicrobial stewardship. And I would like to stress that there's a lot of things we could talk about if you talk about the future of antimicrobial stewardship. But I would specifically want to target this talk on individualized diagnosis and therapy. I believe this is an evolution that we see in healthcare as a whole, and I feel that it's going to be an important part of our shaping of antimicrobial stewardship in the future. And for that, we need to take a step back and look at the role of epidemiology in prescribing accurate primary antibiotic treatment. Now, I'm a doctor, and I'd like to start from a clinical perspective. So let's start in the emergency department. This is Mr. Jacobson. He's a 70-year-old man. He has type 2 diabetes, hypertension, and chronic heart failure. And he has a 2-day history of fever and productive cough. Apart from that, he's progressively dyspneic. He can hardly speak. He's restless and obtunded. And on examination, you find diffuse bilateral crepitations, right, more than left, and a saturation of oxygen of 85% on room air. He has a highly elevated respiratory rate of 38 per minute. And finally, he's also hypotensive with a blood pressure of 76/34, and no urine is found in his bladder when he's catheterized by the nurse. His EKG shows new onset atrial fibrillation with a ventricular rate of 120 more or less, and his X-ray shows an infiltrate on the right side a bit more than on the left side, and it is congruent with the diagnosis of severe community-acquired pneumonia. Now, what will you do now? Well, as an intensivist, I'm probably biased, but I would probably first intubate and ventilate this patient, give him fluids, give a central line, start him on vasopressors, and potentially also on an inotrope and transfer him to the ICU. But obviously, that was not the question that we want to discuss here. The question is, what about antibiotic therapy? Now, I can't talk to you directly, but I guess you would be shouting different names of antibiotics, and I would probably say, well, in the Netherlands we use ceftriaxone plus erythromycin or ciprofloxacin, and some might say, well, we would treat a potential infection with MRSA, so we would add vancomycin or teicoplanin, whatever. So antibiotic therapy is very dependent on where you are and what the epidemiology is. Now, in terms of deciding what to treat in current practice, with what treatment to start, we have two important sets of epidemiological data that we use for that. And the first set of data is about pathogen identification. So which pathogen is most likely causing this particular infectious disease? And we can, excuse me, that was the light coming out. And for that, we look at international guidelines, sometimes national guidelines or regional guidelines, where it is discussed, where papers discuss the relative epidemiology of pathogens causing this particular infection. Now, that's not the only thing that is important, because apart from having the pathogen identified, we need to know what the resistant pattern is for the most common used antibiotics. And this is data that's sometimes found back as well in the international guidelines, but can be found also in publications from, for example, ECDC, but also from national databases, national publications yearly on sensitivity of different pathogens. Now, for pathogen identification, there's usually not a large difference transnationally right? Strep pneumonia is still the most common pathogen causing community-acquired pneumonia, whether it's in the Netherlands or it is in Spain or in any other country. However, for resistance patterns, this can be very different. Now, to show you how difficult this sometimes can be to really grasp the importance and the relevance of these pathogens and of these resistant patterns, I want to show you some data that we collected from the Netherlands, where, as you know, the Netherlands is a small country that is pretty well known for its management of antibiotic use and of promoting antimicrobial stewardship. We rely on data based on the data that is provided by the different laboratories in our country. But as you can see here, laboratories in the northwestern part and the southeastern part of our country hardly contribute to the level of resistance, the level of susceptibility that we actually provide in our national guidelines. So this all seems very rational, but be aware that there are potentially zones in the country where this is not, where actually these data don't count. Right, so and as you can see here, there's actually also within countries quite a difference in sensitivity. In this case, for of Klebsiella pneumonia for coamoxiclav and ciprofloxacin. So very much dependent on the quality of the measurement over the country, that you will see that there's differences in resistance that have to be taken into account. And here's another example of the sensitivity of Staph aureus isolates. And as you can see in the part of the country where the least of the isolates have been sent to, which is the northwest part of the country, also there the resistance rates are highest, and they sometimes have a difference of multiple percent. So it makes sense, and you have to ask yourself the question, why is this happening? Again, let's get back to our patient who's now intubated and ventilated and needs antibiotic therapy. What is it that we then normally do? Well, we look at the guideline and look what's in the guideline. First, we're looking at the microorganisms that we want to treat empirically in cow. And as you can see here, based on different environments, either outpatient, hospital, or intensive care units, you see a relevant frequency of those pathogens occurring. And this is what makes you decide about the treatment that you're going to start. So this is all common knowledge, I know, but it has to be very clear from the start when we are entering this discussion. So here is the national guideline telling us that in severe community-acquired pneumonia, for which ICU admission is necessary, we will treat a patient with either moxifloxacin or the combination of a second or third generation cephalosporin plus ciprofloxacin, because we want to treat strep pneumoniae, Haemophilus influenzae, we want to treat Staph aureus, Legionella, and sometimes we also want to treat atypical bacteria. And that is why we treat this patient with such a broad spectrum antibiotic, with broad spectrum antibiotics to start off with. And obviously afterwards, we will de-escalate as well as possible. But then again, you will understand we will have been giving this patient broad spectrum antibiotics for a couple of days. So what can we say about the role of epidemiology in prescribing? Well, we feel that the epidemiology of causative pathogens should determine empirical treatment in the guidelines. However, we also feel that that is not the only thing that happens here, and that we do see an important role for the severity of illness. So the broadness of the spectrum where we treat very much says something about how much risk we can take, we dare to take, right? Do I dare to wait and see? Well, probably not in a patient who is in the ICU. Probably yes in a patient who I'm seeing in my general practitioner appointment. But apart from the role of severity of illness, it's also disappointing what the epidemiology gives us, right? In about 30 to 50% of community-acquired pneumonia, no causative pathogen is actually isolated. So we don't actually know what the real distribution is of community-acquired pneumonia. And also, a little bit disturbingly, we had always hoped to be able to discern a certain type of microorganism from the clinical symptoms or the risk factors. So we would have loved that to predict the pathogens. And atypical symptoms like dry cough or no fever or hyponatremia as a lab abnormality or specific signs on the X-ray, we would have liked that to really isolate a potential pathogen, but unfortunately, that does not seem possible. So, just to show you a couple of graphs I found interesting to show you how much we are actually treating patients without really observing epidemiological factors. This is a distribution of Legionnaires' disease in the Netherlands, and it's data over 4 years, and it actually shows that all the Legionnaires' disease that we have actually happens in the summer months. So we hardly see any Legionella in winter. But for the same matter, we still treat Legionella always, and we always take our tests in the summer, whether it's summer or winter. So that's an important thing to mention. And on the same errand, I would say, if you look at the occurrence of Staph aureus caused pneumonia and influenza associated community-acquired pneumonia, you can see that this only happens in the winter months. So starting from November until March at the latest. And still in summer, we always treat patients with antibiotics also covering Staph aureus pneumonia. So here is our wish. We would like to have more decision, like we would like to make our decisions more based on the epidemiology, but for some reason we let ourselves distract from that and give antibiotics in a totally different way. So what would prescribing in an ideal world look like? In an ideal world, we would like to have control and knowledge of all individual determinants and risk factors and their role to predict that causative pathogen, and hopefully also the sensitivity of the pathogen. So that would include to know everything about local epidemiology, about seasonal variation, to know about the severity of illness, of what role that plays, to know about other patient risk factors, previous colonization status, previous treatment with antibiotics, and also specific patient signs and symptoms. If we would be able to control for all these factors and use those to appropriately prescribe our antibiotic, that would take us a bit further. As a matter of fact, if we could do that, we would be very close to what you could call the Holy Grail. If we would be able to prescribe exactly the antibiotic oriented at the pathogen that is responsible for this particular disease, we would be making a great step in improving prescribing. Now, what could be potential solutions to that problem, and how could we then maybe get a little bit closer to that Holy Grail? And first of all, I want to discuss the role of rapid diagnostic testing, because that is something that in the last decades has become more and more important and could lead the way towards a more appropriate prescribing process. So, resuming, local epidemiology and clinical features are just not robust enough to predict identification and the resistant patterns of the pathogens that cause the disease. However, rapid diagnostic tests could, in an ideal world at least, replace the need for empirical therapy. Yes, it could replace that need if we know directly what is the pathogen that is causing that specific disease. We would not need to rely on previous methodology, previous knowledge of epidemiology. We would not have to consider all these other factors. So it may actually bring us a bit forward in deciding what is the appropriate therapy at the moment of presentation of a patient. Now, this is a nice study that shows various rapid tests that are currently available or still under development for identification of antimicrobial resistance and for identification of the pathogen itself. So as you can see here on the top layer, you can see the different new methods are available for identification and those looking at resistance patterns. And these are before the culture is positive, and this is in the most conventional way, and these are afterwards, right? So the most often used is the MALDI-TOF, for example, which has really greatly decreased the time to determination of resistant patterns. But you can see many different tests that are molecular, that are PCR tests, that are all kind of different biochemical tests, and they could all have an influence on early identification, and as such make empirical therapy as such not necessary anymore. So the key message is here that we need to move to more rapid culture-independent microbiological identification methods, because those methods allow us to decide early and to decide about antibiotic treatment early. Especially in specific populations, I can imagine that in a patient that we just discussed with a septic shock, in this case due to severe community-acquired pneumonia, that it could be very useful to have this kind of information available. But also in patients that were exposed to antibiotics before sampling or have other risk factors for MDR. I think all of these factors, these populations would greatly benefit from having more rapid culture-independent microbiological methods. Identification method. So what I find a very intriguing study, actually, even if it's about if you will, a MALDI-TOF, which you know will take some more time than deciding directly on presentation of a patient. I think it's a very interesting thing to see here that while we have a pre-intervention period where not MALDI-TOF is used, but just regular blood culture identification and susceptibility is performed, and in the second in the intervention phase, the early identification by MALDI-TOF and the pronouncing of susceptibility will greatly influence the care, and will greatly influence the time to effective therapy, as you can see here, from 30 hours back to about 20 hours after admission. So that means that time to optimal therapy also greatly reduced, about half reduced, which I believe is a very important step into future stewardship methods. So early identification, even if it's after starting empirical therapy, broad spectrum therapy, can greatly improve de-escalation. And I think we're doing this. A lot of us are doing this, but this study actually shows that if you really focus on it and are very early in your picking this up and integrate it in your A-team intervention, then it can actually greatly improve the quality of use, but also importantly patient outcomes. So now this study is another example of using new technologies to decide earlier about antibiotic therapy. So this is a prospective randomized controlled trial evaluating outcomes associated with rapid multiplex PCR. I'm just calling that RM-PCR, which is actually able to detect bacteria, fungi, resistant genes directly from positive blood cultures. So in this study, patients with those cultures underwent stratification into 3 arms, which you can see here also in the figure, with the control arm, which just has standard BCB processing, and then the rapid multiplex PCR arm with templated comments, or the rapid multiplex PCR reported with real-time audit and feedback of antimicrobial orders by a stewardship team. And here you can see that actually what is the importance of that stewardship team on top of what we find here. But as you can see, in the two former arms, the rapid multiplex PCR and the rapid multiplex PCR plus the stewardship intervention, the identification is obviously very early. But as for the de-escalation, the decisions taken from the results that we find very early with these methods, it would still need appropriate management and appropriate pointing out by the stewardship team that you can actually de-escalate therapy. But if you do so, at least this will, again, we're looking at 24 to 36 hours of differences between the regular old-fashioned way, if you will, of doing this and the way in which we can do it with multiple new strategies. So, and then finally, discussing just another type of fast or early diagnostic, the molecular detection of pathogens, was studied in a multi-center cluster randomized trial conducted during 2 consecutive periods, which was a control period where we'd have a standard diagnostic workup and an intervention period where also additional testing was done with a light cycler. And which is a molecular detection method. So for septic patients, it was found that this molecular detection rate was much higher during the intervention period and during the conventional period, where standard diagnostic workup was used. So that this is an important thing, because overall turnaround time, therefore, was much shorter during IP, the intervention period, than during the control period. And addition of such a molecular detection method actually improved microbial diagnosis at first, but it very importantly shortened time to start species-specific antibiotic, and thus, add to important antimicrobial stewardship measures. So at this moment, I think what we can say about the role of rapid diagnostic testing, that this is a very interesting field of work, and as it becomes more prominent and huge amounts of diagnostics tests come to the market, I think it's important to do a couple of things. And first of all, we need to recognize that this can play a really important role in changing our stewardship objectives, but it can also it does also prompt us to have a bit of diagnostic stewardship as well. We can't use all of these tests, and we have to be really careful that we use them too much, because that will drive up costs as well enormously. So this is a challenge for us in the future. First of all, we have to start using them. I mean, we were already using them, but we should use them more inside of our stewardship procedures, but we also have to take care that we don't overuse them, right? So I still feel that local epidemiological considerations are relevant, and you have to be able to interpret these tests as well. So you always have to consider epidemiological considerations, but it's clear that we can't do everything only from epidemiological considerations, and that these tests will help us do it better, actually. And again, I don't still think at this moment that there's an excuse to refrain from taking classical cultures. This is something that we're seeing more and more, that rapid tests are used, and people tend not to use or to perform classical blood cultures anymore, which I believe is still pretty premature at this moment. I wouldn't recommend that at the moment. Now, what I find an increasingly interesting field of research is obviously the field of machine learning, of artificial intelligence, and I don't think there's a lot of research already going on in this field, but it's definitely something we should be focused on. And there have been some studies that looked at the role of AI in predicting if a patient, first of all, has a bacterial infection, and then second of all, what is then the pathogen and the resistance pattern of the infectious agent. So one of the studies is the one that is prospected here, where the use of administrative data on the individual, on household, on background, etc., on hospitalization, prescription histories, together with the information that is provided by the doctor on examination, is put in a model where artificial intelligence processes are able to look at large-scale data to predict risk of a bacterial infection. And as a matter of fact, in this study, the machine learning model could actually reduce prescribing by a relatively important percentage. So AI is there in many different sectors, and also increasingly coming to the field of antimicrobial stewardship. And I think mainly in the in discerning the pathogens, the early recognition of pathogens, it can be of great help. Now, an intriguing example of the use of machine learning or AI to guide empirical antibiotic choice was presented at the last live ESCMID Symposium, now already more than 1.5 years ago, but still a very interesting study that was done by a group from the UK, where they extracted routinely held clinical data for patients for whom a gram-negative bacteria was isolated from the blood or urine over a 7-year period. And they looked at very large group of patient admissions, about 27,000 admissions and antibiotic initiations. And by doing so, they created a sort of an antibiotic risk scoring tool, and then trained, as it called, an XG boost MLA, a sort of decision algorithm from a popular open source tool. It was used, and then they compared the performance of medical staff, just a normal medical staff that would acknowledge that, would judge that from the tool, and from the trained algorithm, if you will. And they trained it how to appropriately select for either coamoxiclav, piptazo, and carbapenem therapy. So these were considering more than 2,000 empirical antibiotic initiations, which makes it it's a large data set, as you will understand. Now, what they found is that the simple scoring tool actually predicted resistance to coamoxiclav and to piperacillin tazobactam, and actually it did it better than the normal doctors. But the MLA, so the algorithm, outperformed the tool in both cases, and compared to medical staff, I believe that the MLA would have resulted in about 20% increase in appropriate prescribing, with a 27% reduction in necessarily broad agents. So again, I mean, this is very early work, and I haven't seen this published yet, but it's a very interesting and intriguing development as we are getting ready to use these data. Remember the talk I held yesterday about how to integrate data from your daily evaluation of all the factors that you have available in your electronic medical record. If you would be able to do that and still have these kind of algorithms run with it, and see how that could actually help you predicting what the resistance rates are, or what the most likely pathogen is, then I think we would ultimately see these kind of intelligent advice replacing the current didactic empirical guidelines as we have them now, that are very much more, well, if you will, theoretic, and still need a lot of adaptation every time that we use them. So to go short, I think machine learning can really start playing a more and more important role, especially when combined with things like early diagnostic testing. So here we are, I think, a little bit closer maybe to the Holy Grail, but still a way to go, obviously. Now, in the meantime, there's a couple of things I still would like to say as the end of this talk, and I think that apart from this being a technical thing, this being a technical decision, whether to use rapid diagnostics, whether to use intelligent algorithms to help us choose appropriate empirical treatment, there's also a psychological part to it. Because, as always, we need to choose some kind of threshold for coverage, right? So what kind of threshold would we be happy with when we start treating patients? And what is the reason? Why do we have so much trouble with accepting a certain threshold? Does it have to do with a lack of knowledge, with a lack of experience? Are we fearing litigations? Are there maybe cultural factors? Is there some uncertainty avoidance there? So I'd just like to spend a couple of slides on that, because I feel it's an interesting topic. Every time when we prescribe, we think about a threshold. We think about what would be our maximum threshold that we would feel is acceptable. Now, this very interesting study was done by the group of Nick Damon, where they studied a threshold for empirical antibiotic treatment for serious bacterial infection. And they used a sort of a scenario-based survey study. So they sent out a scenario-based survey among more than 200 residents in internal medicine and also in attending physicians in any field of internal medicine, so gastroenterology, general internal medicine, but also infectious diseases. So they provided these interviewees, or sorry, these residents and attendings with scenarios that varied by infection source and severity. And then every time, so they presented the scenario, and then every time asked the doctor, so would they allow for, what kind of coverage would they allow for? And so you can imagine that many different kind of scenarios then existed, depending on severity of illness and on source. And one of the interesting conclusions from this study was that all doctors actually allow for approximately a 80% coverage threshold. So they would allow for 20% non-coverage in moderate septic patients, but in severe septic patients, obviously that percentage would go up, which is understandable, to about 90%, but still 10% of non-coverage would be acceptable to most residents and attendings. Now, interestingly enough, a severity of illness and ID, the fact if a patient, if a doctor was an ID specialist or not, predict higher coverage thresholds. So maybe contrary to what you might think, ID specialists would not accept a lower coverage, and they would prefer a higher coverage of the threshold than their colleagues who were not ID specialists. So an experience, a general experience in years and a less prescribing intensity allowed for a lower coverage. So this is quite interesting from a point of view where we believe that obviously the best treatment is advised by ID specialists. Well, maybe they would keep too high of a coverage thresholds. Now, in that matter, I'd like to discuss something else, and that is whatever cultural dimensions could have to do with choosing these coverage thresholds. So, but for that, I need to introduce Hofstede to you, and some of you might know this. Hofstede is a psychologist who has actually developed cultural dimensions. So these are actually 6 different dimensions by which cultures can be recognized, if you will. So on every of these different dimensions, a culture is scored, and every culture has a different set of dimensions. And in one culture, For example, individualism is more important than in another culture, whether that could be different for another dimension. Now, there's 6 different cultural dimensions available. Power distance, which means how much inequality is there, how far are you from your boss. Individualism, how much are you dependent on community? Is your culture, is the culture where you live in very much oriented at individualism or at collectivism? The masculinity, the preference for achievement versus the caring for quality of life. But importantly also uncertainty avoidance. How afraid are you? How afraid is a culture, is a certain culture of something unexpected, unknown, away from the general status quo? The long versus short-term orientation, etc., etc. And the restraint versus indulgence. So these are the most important cultural dimensions that we know. And this is an example of how cultural dimensions are different per country. So for example, you can see that power distance is a very important part of cultural dimensions in China, where there's a large power distance. Well, it's far less important in the United States. And uncertainty avoidance, for example, is a very important part of culture in Brazil versus very low in China. And obviously, the example of China on the long-term orientation, which is well known from its economic endeavors, is strikingly different from the one in the United States, where it looks like it's much more of a short-term orientation. So these are well-known and well-accepted criteria for cultural dimensions. And interestingly, what we see, and this is already old data, is that there's a quite strong correlation between inappropriate antibiotic prescribing for cold, for common cold, for flu, for sore throat, etc., and 2 different cultural dimensions, and those are an uncertainty avoidance, which is noted here, but UAI, most importantly, but also masculinity. So cultures that are very masculine and have a very high rate of uncertainty and avoidance are more likely to inappropriately prescribe antibiotics for colds, flus, and sore throats. And here's another just short table where you can see the distribution of an uncertainty avoidance index over the different countries. As you can see, this is all European countries. And as you can see, countries like Belgium and Italy and Portugal, most of these countries are Southern European countries, as compared to the Netherlands, but mainly, for example, compared to Denmark or to Ireland, are countries where there's a very low uncertainty avoidance index. And that makes sense. So if you then actually look at real-time data, then this study from Cheng shows that when comparing proportion of antibiotic prophylaxis over 24 hours, so prolonged prophylaxis, which is not appropriate therapy, as compared to cultural dimension, again, you can see here that uncertainty avoidance, the higher the uncertainty avoidance, the higher the proportion of patients who were given antibiotic prophylaxis for over 24 hours. So there seems to be quite a strong relationship between those cultural dimensions and inappropriate antibiotic prescribing. And I think that coverage threshold is in the same vein here, and that uncertainty and avoidance mainly, and maybe also masculinity as a culture is associated with more coverage, with the need or the feeling that we need to have more extensive coverage than maybe strictly necessary. So, in short, I'm aware that it's a little bit a couple of different subjects altogether, but I felt that that I could draw the following conclusions. I think the future of ASBs is likely in diagnostic stewardship and artificial intelligence. We've seen such a huge development in that field, and now only experiencing the first important well, developments in artificial intelligence, that this is something that's going to shape our future and shape the role of antimicrobial stewardship. So and for the rest, I would say that guidelines still rely on epidemiological data for identification of causative pathogens and resistant pathogens as a background for empirical treatment advice, and that is something that's maybe starting to be a bit old-fashioned. Well, we still have to use it until we wait for those new evolutions. We must realize that multiple other factors influence decision-making for empirical therapy. That is definitely not only epidemiological data, but also severity of illness and many other factors that may not be that rational. Rapid diagnosis may really help to reduce the need for empirical therapy, but it has to be used wisely too. So apart from just introducing them, we have to think about a way how we can appropriately use them. So that is what we would call diagnostic stewardship. Very important to also take a look at that. So innovative predictive approaches finally are welcome, and their way, and I think they could play a huge role, but we still have to realize that even if they would be very welcome, they may also prove difficult to implement, right? Remember that when we want to implement new strategies, we have to really look forward to look at reasons why people who in the end will be prescribing will be looking at those and will see them as a potential barrier, or there will be barriers to actually implement them. And as an example, there's a lot of these AI tools now available, and some of them are hardly accepted by practitioners. This is not in the field of stewardship, but it's coming to us in any way. And many of those innovative AI approaches need to be really seasoned before they can be implemented in real-time practice. So it's a warning that also in these interventions, we need to see how we can safely and adopt them into real-time practice. And finally, as an extra, I discussed the high coverage threshold, and something that may still seem and still be more of a psychological or maybe a cultural influence than it is purely based on true epidemiology. So I hope I've amused you a little bit with my talk on the future of antibiotic stewardship, and I hope to be able to discuss with you in the future. And if you're interested in this course, I already made the presentation yesterday. You can always go to the website and be a part of our group. Thank you very much.